special guest lecturer today. Really happy to introduce Dr. Michael Ritchie. Dr. Ritchie graduated medical school from Brody School of Medicine, and then did his EM/IM residency here at Kings County. He started residency with me, and then did the 5-year program, so stayed on for an extra year, and then did a critical care fellowship down in East Carolina. Came back as faculty for some time, so was here practicing again and teaching our residents. And currently he practices critical care medicine at University of Louisville, and he's going to come talk to us about right heart failure and emergency medicine. And Dr. Ritchie's biggest legacy is he actually created clinicalmonster.com. So still something we use every day, Michael. And I'm sure it doesn't look much like what it was when you did it, but it's a legacy that he can be proud of. So thanks again for being here, and a big round of applause for Dr. Ritchie.
Thank you very much. So I'm going to go ahead and start talking about right heart failure and emergency medicine. I feel like there's probably a lot to go through. And so I hope it works well to pertain to emergency medicine. I don't have any disclosures. All right, so here's the objectives. We're kind of recognizing right heart problems. What are the hemodynamics? How to differentiate what type of right heart failure you have? What's the pathophysiology? And then diagnosing and treating. So the reason that I really got into it was that I felt like it was often ignored and not taught very well, at least as I was kind of going through fellowship and different types of things, is that I didn't feel like it got everything that it needed. It does only make up about 3 to 9% of all acute heart failure admissions, but it still has the same mortality as LV failure, and maybe even higher, but you're looking at like a 5 to 17% mortality of everybody that gets admitted. So it's something to be taken seriously whenever you're looking at people in the emergency department. And this was what I was kind of always taught from like med school on, was that if it was a right heart problem, there wasn't really much to it. You just gave them a bunch of fluid, you maybe got a right-sided EKG, and then you did a cardiology consult. And I'm hoping that by the end of this, you'll realize that that's not what you need to be doing, and to look further into how to treat these patients. So the first thing we're going to talk about is recognizing right heart problems. And it can be really difficult to kind of say, hey, I think this person's got something going on. And why is it so difficult? And I think it's difficult because everyone knows that if you're short of breath, you start thinking about, is this heart failure? Is this pneumonia? Kind of going down that road. But in right-sided heart failure, you're missing, for the most part, any lung findings. You're getting all those right-sided problems. You're getting the lower extremity edema. You're getting the hepatic congestion. You're getting the JVD. And unless you're really looking for it, you may miss that because they'll be on room air, and you'll say, well, they can't be in heart failure, they're on room air. So I think it gets missed a lot. And you don't always have to be a edematous. This lady has right heart failure, and you can see she's got a lot of pressure. As you can see, her venous distension that she has. But if you looked at her overall, she's very thin and doesn't have that lower extremity edema that you maybe associate with heart failure. Whereas this person is on the opposite, right? So you have somebody that's obese that you may not be able to recognize that their size and their edema isn't related to right heart, that you assume it's related just to their overall body habitus. And so it can be really difficult to identify these people. So we're gonna introduce 3 cases up front and then go to them later on. But here are 3 cases that I dealt with as an attending at East Carolina University. And so if you look at these, is that oftentimes people will pull up an echo, they'll scroll down, and they'll say, look, the LV cavity is small, the LV is hyperdynamic, EF greater than 70%. This sounds like somebody that if they were hypotensive, you would say, hey, I think this person's in septic shock. They're clearly underfilled. They need a bunch of fluid. Or you flip to this one and you look and you're like, hey, look, they're EF 60%. They're probably fine. let's go ahead and look for other causes. It's not related to the heart. And then the same thing with this one. The LV is normal in size. The EF is normal. EF is 60 to 65%. Is that oftentimes you'll say, okay, you know, the EF seems okay. The LV seems all right. Maybe this is pneumonia. But let's kind of look at how right heart hemodynamics. We'll kind of look through all the pathophysiology, and then we'll come back to the cases. So as a big lover of physiology, I always think it's helpful to go over the hemodynamics. As we know, cardiac output is broken down into heart rate times stroke volume. And then stroke volume is further broken down into preload, contractility, and afterload. And whenever you're dealing with these in terms of measurements, preload, you can think about it as kind of your venous return, that blood volume that's going back to the heart. Your contractility, you can think of it as just your overall RV function. And then your afterload is going to be able to deal with your pulmonary arteries. So when you're talking about how the right heart's going to work, those are the three things that you're going to be looking at. If you really want to get at the physiological level, your preload is your right ventricular end diastolic volume. It's that volume at the end of diastole that puts stretch on the ventricle that allows your Starling forces to work. With contractility, it's actually your stroke work. So it's the ability of the change in pressure times volume. And so it's the stroke work of the RV itself is considered the contractility and a good measurement. And then your afterload is your pulmonary vascular resistance. It's the resistance that is being put against the RV that it has to work against. So starting to talk about preload, everyone should recognize the Starling curve, where the idea is that if you add volume, then you're going to increase the stretch, which is going to increase the Starling forces. It's going to put you higher up on the curve, which should improve cardiac output to a point. And then you start seeing that curve flatten out and even start descending, where the more volume you give, the worse that it gets. And the RV does have a Starling curve the same as the LV. And the RV is designed, it's thin, it's kind of hanging out on the side of the left ventricle. And it's designed so that it actually handles preload very well. And here's an example of how much extra work it has to do if you add preload. So the RV does minimal extra work as you get more preload, whereas the LV that's big and thick, it's not designed to take a lot of preload. It's designed to work, to squeeze. And so the stroke work goes up considerably with the LV, whereas the RV, it doesn't seem to be bothered much by preload. And then contractility is also different in the RV compared to the LV. So the LV constricts concentrically, whereas since the RV, since it's mainly just a free wall attached to the LV, it actually shortens. So it doesn't squeeze in. So if you're measuring performance, you want to look at how much it's shortening as opposed to how much it's squeezing in inwardly on those things. And then your RV afterload is kind of your pulmonary artery pressures, but also mixed with what's the pulmonary vascular resistance. So your pulmonary artery pressures normally are like 25/12. When you're talking about resistance, though, it's a derivation of Ohm's law, which is change in pressure over flow. So if you rework the equation, your pulmonary vascular resistance is your mean pulmonary artery pressure minus your left atrial pressure. So it's the pressure at the beginning of the system minus the pressure at the end of the system. And then the flow is cardiac output. So normal systemic vascular resistance is going to be like 800 to 1200. This one says 900 to 1400. Pulmonary vascular resistance, a lot of times you'll actually see it in Woods units. And by doing it in Woods units, then that's how you're going to see it a lot of times mentioned from a pulmonary world. And even in the cardiac world as well. But you may see it in dynes. All you do is multiply it by 80, and that's how you're going to get the differences in. The opposite is true for afterload. Since the RV is thin, it actually hates afterload. So here's an example of what does the stroke volume, which heart rate times stroke volume is your cardiac output, what happens to the stroke volume whenever you increase afterload? So the LV is big and thick. And so if you add more afterload, nothing really happens. It's designed to push against increased afterload. It's going to do well with that for the most part. Whereas the RV, you can see as soon as it starts getting some increased pressure on the afterload side, it immediately starts dropping the stroke volume at a pretty rapid rate. It's just not designed. It's thin. It's going to not be able to work well against it. So when we go to differentiate the types of right heart failure, it makes sense that whenever we do it, that there's 3 different types, and they're all based on the things we just talked about. You can have a primary preload problem, a primary contractility problem, or a primary afterload problem. The first one we'll talk about is a primary preload problem. That's really rare as a primary cause. It's actually very common as a secondary consequence to the other ones, but as the entire reason why they go into RV failure. You have to have, it's usually more seen in children as they have a large ASD or VSD. And it's usually diagnosed fairly quickly just because of how large the defects are. So I'm not going to really talk about this one any more than this one slide, just because I don't think that you're even going to see it much in the pediatric emergency department, just because of they should be able to be identified before then. But acknowledging that it exists and it can be an issue. Contractility problems. The main one you're going to deal with would be RV infarct, right? And here's your classic ST elevations, 2, 3, AVF. And then always on the boards, what do you do next after this? You're going to do your right-sided. You're going to look for elevation in V4R. And then you're going to be able to say, hey, I think this person's having a right-sided MI. And yes, that's definitely common. It's not that common compared to afterload, which is going to be mainly the ones that you see, but it does exist and you should be able to know about it. And then I would say 90% of the patients that you would see with RV failure would be related to an afterload problem. So the reason that it's so common is that it is a consequence of multiple disease states. So there's a long list of diseases that at the end result down the road is pulmonary hypertension. And so a lot of people are going to have pulmonary hypertension. They're going to have that increased afterload. And then as they get to a tipping point, that increased afterload is going to start causing RV failure. So there's systemic issues, and then there's acute and chronic diseases. So there's the acute things that happen that make people's afterload go up. And then there's the kind of acute on chronic or chronic things that make people go up on afterload. So we'll talk about kind of the systemic responses first. Acidosis and hypoxia are huge. The lung, whenever it gets hypoxic or whenever it gets acidotic, the pulmonary vascular resistance goes up considerably. So you can see that if someone's pH goes from 7.4 to 7.1, there's a 200% increase in their pulmonary vascular resistance. And if you add hypoxia into that, then you can have up to a 300 or 400% increase in their pulmonary vascular resistance. So if somebody already has some underlying pulmonary vascular disease, leaving them in an hypoxic or acidotic state can really stress their heart, because their pulmonary vascular resistance is going to go up considerably, and that right heart's going to have to work that much harder. And then always the one that's a little bit interesting to think about is positive pressure whenever it comes to pulmonary vascular resistance. So if you think about the patients that we put on BiPAP or the patients that you're intubating, there's actually a curve, a distribution. If you put them on positive pressure and put too much positive pressure, you overdistend the alveoli, you collapse the capillaries, you're going to increase their pulmonary vascular resistance. If you don't put somebody on positive pressure that needs it and they have atelectasis and collapse, then the atelectasis, because of the way that the lungs work, actually leads to increased pulmonary vascular resistance. So the lungs are designed that if you have hypoxia to an area, they'll start constricting their pulmonary vasculature. So if you have a whole area that's atelectatic, then what it's going to do is just start squeezing those down. You're going to increase PVR. So if you under PEEP them, then you can lead to atelectasis and PVR. If you over PEEP them, then you can lead to increased PVR and damage. And I think everyone probably has a story of that submassive or massive PE, and you get them ready, they're struggling, they're tachypnic, and you go to intubate them. And then as soon as you put positive pressure, once you intubate them, they just die. And that's because they're barely hanging on. They have this super high pulmonary vascular resistance from their large pulmonary embolism, and then that little bit of extra positive pressure just tips them over the edge, and the RV can't compensate, and then they go into cardiac arrest. And typically these people don't come back. I know this has happened to me a number of times, unfortunately, where there's just nothing that you can do in those situations. But it is something to keep in mind that if you suspect somebody has significantly high pulmonary vascular resistance and super high pulmonary pressures, is that you maybe want to avoid positive pressure at all costs if you can, and kind of leave them to kidney, kind of leave them doing what they can do without putting the positive pressure on. So how can you identify patients at risk in the ED, right? How can you look and say, all right, is this patient more at risk than the next patient? And so not that you necessarily need to know about this in terms of how it's broken down, but it is helpful. So there are pulmonary hypertension groups. And these are ideally, whenever you identify somebody with pulmonary hypertension in the medicine world, is you would identify them as group 1, group 2, group 3, group 4, group 5 pulmonary hypertension. And then that way it helps you kind of look at the etiology of what's going on. And so they are broken down into groups. So group 1, you're looking at kind of idiopathic connective tissue diseases, HIV, cirrhotics. So cirrhotics are huge for pulmonary hypertension. If you have a cirrhotic patient that seems decompensated, is that I always look to make sure, look at what their right heart's doing, because the new guidelines actually recommend that as an outpatient, every year that cirrhotics should get screened for high afterload and pulmonary hypertension. Group 2 is just left heart disease. So if you have systolic or diastolic dysfunction or valvular disease, it just creates this high pressure going backwards, and it leads to pulmonary hypertension. Group 3 is your lung disease, so COPD, ILD, OSA, OHS. So you can imagine all the people that you have coming into the emergency department with COPD, or they have history of obesity with OSA and OHS, is that they're going to be at increased risk for having right heart failure as well. So it's just something to keep in the back of your mind, is looking for people and saying, this person has a lot of risk factors for pulmonary hypertension and right heart failure. Is it something we need to look into further? CTEP is another one. It's become more and more recognized as we've actually found treatments for it. This is a embolectomy, actually, where you take the chronic clot out. That's why it's white. So this was just a chronic clot sitting in there. It didn't dissolve with any coagulation. But if you can imagine that sitting in the pulmonary arteries, that's going to create a lot of obstruction, which is going to create a lot of resistance. So CTEP is chronic thromboembolic pulmonary hypertension. And then group 5 is just miscellaneous. So sickle cell, large sickle cell population in Brooklyn. So when these people start not doing well, it's a good idea to really look and say, you know, maybe their right heart has something that's not going well with it. Sarcoid. Chronic renal failure is another one that will do it, which is another high population as well. So now we're going to go into the pathophysiology of like how right heart failure, why it's so dangerous, why the mortality is so high. This is a pretty famous picture that they did looking at PE physiology, but it's the same in somebody that has increased afterload that decompensates, so it has an acute on chronic kind of exacerbation. But when you have really high afterload, if you can imagine, the RV dilates, and as your RV dilates, your tricuspid valves don't grow with it. So as the tricuspid valves separate, you're going to get tricuspid regurg, you're going to get reversal of flow. Also, as you dilate that RV, it's going to be increased tension across the wall. It's going to just push against that thin RV. And the RV thin wall is not designed to have a lot of pressure against it. And that'll actually lead to ischemia just from the pressure being pushed against the wall. Because the blood's going backwards instead of forwards, is that you now have increased RV oxygen demands because it's working harder to try to pump the blood forward. And then you have increased ischemia because you now have increased demands without increased supply. This all leads to decreased RV contractility. The decreased RV contractility decreases the output, which then causes LV dysfunction, which then causes hypotension, which decreases perfusion, which then decreases oxygen delivery, which worsens ischemia, which worsens contractility. And you can see that you end up in this spiral where the decrease in contractility is a feedback mechanism that you now have worsened ischemia, worsened contractility, which leads to worsened ischemia, worsened contractility. Excuse me. And so whenever they have these issues, is that they're gonna do real poorly real fast unless you can break this cycle. So as soon as you identify somebody in this spiral, whether or not it's acute PE or it's acute on chronic RV failure, it's a matter of what can I do to stop this cycle? What can I do to break this cycle? So now we're gonna talk about diagnosing right heart failure, right? So what can I do to say, I think this person's having RV failure in the ED? So echo, I think echo is huge here. If you can be comfortable just throwing an echo on the patient and just saying, look, I think that there's something going on here. Let's take a better look at it and see what we can do. The first thing is going to be RV dilation. That should be your first clue. If your RV is struggling, it's going to be dilated. If you have a small RV, it's rare that you're going to have anything that would be related to RV being your primary problem. If you have an acute PE, your RV is dilated. If you have acute on chronic RV dysfunction, you're going to be dilated. So RV dilation is big here. And this is your parasternal short. And as you can see, your LV is significantly smaller than your RV, and your RV is big and dilated. So that should be a clue that there's maybe something else going on. D sign, I would imagine all you guys are comfortable with D sign, but it's the idea is that there's so much volume and or pressure in the RV that it's actually pushing the interventricular septum over into the LV. And instead of the LV looking like an O, it now looks like a D. There's actually some differences in this. If is recognizing, is it during diastole or systole or both? So if it flattens only during diastole, then it's actually volume overload being the main problem. If it flattens only during systole, then pressure is your really only problem. And then if it's flat throughout the cycle, then it would be pressure and volume overload. So if you can see here, it's the idea that you're going to push that septum over, and it's going to actually make the LV cavity very small. And as you do that, that's going to decrease LV relaxation. So you can cause diastolic dysfunction in the left ventricle due to this interventricular shift. And so the thing is that it's taught like you're not going to have pulmonary edema with right heart failure. That's true. It's a very late finding that you would have pulmonary edema due to right heart failure. If you're starting to get pulmonary edema due to right heart failure, that is a significant amount of shift of the septum over into the LV. And that's obviously a bad sign if you're having that much shift that you're ending up with diastolic dysfunction and decreased filling in the LV. But you can have pulmonary edema due to right heart failure, although by that stage, things are going real poor. All right, so RV preload, how to decide if someone has too much preload, right? Do they have too much volume going on whenever you're dealing with RV failure? So the VEXUS protocol, somewhat new. I would imagine people are familiar with it, but it's the idea is you're looking at venous congestion. If you can say that you have organs that are congested with fluid, then that means they have too much preload. If you have too much volume or so much volume that you have congested organs, then those organs over time are going to lead to failure. So the two most common are going to be the kidney and the liver because of the vasculature and the renal venous congestion. And so they designed this VEXUS protocol. And what the idea is that you're going to look for signs of congestion. In order to feel comfortable doing this, you should be able to be comfortable getting that IVC view and being able to see the hepatic vein, and then being able to shift and look at the portal vein. And then you can also get down into your fast views for the kidney to be able to look at that. You also need to be comfortable with the idea of continuous wave Doppler versus pulse wave Doppler. They're going to look at the Doppler is going to say how is the ultrasound waves doing compared to the movement of blood or the movement of fluid. So continuous wave Doppler we'll have it so it just looks across the entire line of the ultrasound. So it doesn't matter. It's just going to say what's the fastest velocity anywhere along our line. Whereas pulse wave Doppler, you actually set an area, a specified area, and say, I only want to look at what's the movement of the ultrasound waves against the fluid at this certain spot. So that's why you can see the difference between continuous wave and pulse wave. So in VEXIS, you're actually doing that for the hepatic vein and the portal vein, is you're going to specifically identify them with pulse wave Doppler and say what is happening to them. And it's pretty easy once you get used to being able to do it. But the idea is that your vein shouldn't pulse, right? That you should only have blood that's going from the hepatic vein into the IVC, into the right heart. If you have reversal of flow in your hepatic vein, then that means that you have significant tricuspid regurg and that you have reversal of flow and that your venous system is actually pulsing due to your RV dysfunction. So once you identify an IVC of greater than 2 centimeters, then you go to step 2, which is your hepatic vein. And you can see in the severely abnormal is that you have this sinusoidal pattern of this pulsatile blood going backwards and forwards within the hepatic vein. In the portal vein, you can see the same thing, is that you can see that pulsatility. So if you have minimal pulsatility, that's normal. If you have greater than 50% pulsatility, that's severely abnormal. And then renal vein Doppler as well is that you're looking at on the bottom of the line. But again, if you have biphasic flow, that means you have pulsatility in your kidney, and that's going to lead to renal dysfunction. And then also you're going to deal with liver dysfunction if you're doing that, because you actually have reversal of flow and congestion of those organs. So if you see congestion on your organs, then that means you have way too much preload within the venous system. And then contractility, TAPSE. Hopefully you guys are familiar with this, but it's the idea is, like we talked about before, the free wall of the RV will shorten. So the more it shortens, the better the contractility. The less it shortens, the less the contractility. If normal is greater than 2 centimeters, abnormal is less than 1.7 centimeters. So you would do your apical 4 view, and you would do it under M mode, looking at the tricuspid annulus, because TAPSE is your tricuspid annular plane systolic excursion. So if you look at it and you see that you have the normal TAPSE, then your RV function is typically okay, versus if it's going to be reduced, then you're going to end up with issues. And we see this with new PEs is McConnell's sign, right? So the RV, like we said, hates afterload. And if you put a whole bunch of new afterload into the RV, that free wall just stops working. And so McConnell's sign is where you have no movement of that free wall except at the apex. And so basically there's no contractility of the RV because it has such an acute increase in afterload that it's not going to handle well. So looking for that RV contractility is important whenever you're looking at RV dysfunction. And then RV afterload. So the idea with RV afterload is as your RV dilates, and you get that tricuspid regurg, you have a tricuspid regurg velocity. And the higher your pulmonary pressures or your pulmonary vascular resistance, blood wants to go in the path of least resistance. So if it's harder to go forward, then it's going to go backwards faster. So the higher the velocity of your tricuspid regurg, the higher the pressure on your pulmonary sides. And so there's actually a derivation of Bernoulli's equation, which is another physics thing talking about. But the idea is that if you take that tricuspid regurg velocity in centimeters or in meters per second, and you square it, multiply it by 4, and add it to the baseline CVP, which you can estimate, then that will estimate your pulmonary artery systolic pressure. And if your PASP, if your pulmonary artery systolic pressure, your right ventricular systolic pressure, which are the same, is greater than 40, then that means you have a mean pulmonary artery pressure greater than 25, that you have pulmonary hypertension, and that you have high afterload within your RV. So you can get a lot of data by looking at the tricuspid regurg velocity. And this is usually done in the apical 4, just like with the TAPSE. And you want to use continuous wave Doppler because all you're looking for is the highest velocity versus just some velocity at a certain area. So this can be very helpful as well to get comfortable saying, look, I did this, the tricuspid regurg velocity was 3, which made us have an estimated pulmonary artery systolic pressure of 50. I think they have high pulmonary pressures. This worries me for pulmonary hypertension. And then the last thing to consider, when we talked about reasons for high afterload, group 2 is the left heart. And so oftentimes you can have RV failure, but it'll be due to LV failure. It'll be due to chronic LV or systolic dysfunction, chronic diastolic dysfunction, especially mitral disease. Basically every patient with mitral disease, if they have significant mitral stenosis or mitral regurg, they will get pulmonary hypertension if you wait long enough, like 100% of them. Mitral regurg is especially bad for it. So identifying whether or not it's related to the LV is important, because it is going to change your management. If you only focus on the RV and make the RV work better, you're going to start sending a whole lot of blood, if you do the management right, to the LV that may not be ready to handle it. So you definitely want to say, hey, I think this person's having some RV dysfunction, but it seems to be doing due to their LV dysfunction. So I'm going to focus on their LV dysfunction. So to kind of recap for you guys is that if you can get comfortable looking at congestion with the Bex's protocol or a diastolic D sign, you want to get comfortable looking at a TAPSE. And then if you can get comfortable looking at your tricuspid regurg velocity or a systolic D sign. So all these are pretty quickly done. You're just looking at a couple of views and you should have a lot of data to say, I have a dilated RV with congestion, a TAPSE that's decreased, and I have high tricuspid regurg velocities. All those will really help sell your case that this person's in RV dysfunction. And then of course, does the LV look okay, to make sure you don't just need to treat the LV to go forward. All right, so we're gonna kind of look at how to treat RV failure. And this is the one that I really kind of want to focus on and go over, is kind of the management as the primary cause, kind of looking at these things. So again, the elevated preload as a primary cause is super rare, so I'm not going to bring it up as those. Decreased contractility, we know that RV infarct, so you really want to get them, they're either going to get TPA or they're going to get a PCI, maybe a stent. But where does this dogma come from, right? So most people say, oh, they're having RV dysfunction, just give them a bunch of fluid. And so I think that this comes from the ideas that I showed before, is that the right ventricle handles preload well. And it does. If you have no other problems with the RV, it's designed to handle preload well. But if you add afterload issues into there, or you add contractility issues into there, then it's not going to handle preload well at a certain point. It'll start dilating that RV and it'll start leading to tricuspid regurg. And then all of a sudden you have reversible flow and you start ending up with a lot of problems. So it can handle preload well as long as there's nothing else going on with it. And then whenever you deal with RV infarcts, is that they become more dependent on Starling forces. So you need that volume in there to be able to do the squeeze, because it's not able to squeeze on its own. Now, this is what we would see with here, is that you have this inferior MI, and people are saying you can't give sublingual nitro in this situation because it's going to drop your preload and it's going to make things worse in somebody if they're having an RV infarct. And that's true, is that they will not handle hypovolemia well because they are somewhat dependent on their Starling forces. But not tolerating hypovolemia does not mean it likes hypervolemia. So just because you want to make sure that they're euvolemic doesn't mean you want to fluid overload them. We don't say people don't like hypoglycemia, so we should make everybody have a sugar of 400, because now we're not nowhere near hypoglycemia. It's the same thing with here, is that, yeah, you need to make sure that they're not hypovolemic, absolutely. But you also need to make sure that they're not hypervolemic. So just make sure you're aware with these RV infarcts. Hypovolemia bad, but also hypervolemia is also bad. And then the main one, like I said, most of the people that you'll see whenever they're having legit RV failure, cardiogenic shock is going to be related to elevated afterload. So there's a great algorithm in 2014 that kind of looked at how to treat this. And I'm going to kind of go through it step by step. So as you can see, the very first thing that they mentioned in this algorithm is there excessive preload. That's how important the preload is. If there's too much preload on the RV, it's going to over distend it, and that's what's going to cause a lot of problems. So immediately you want to look for your excessive preload. So this is where you're looking at your diastolic D sign, you're looking at your VEXAS protocol. And then you want to start going towards volume reduction. Again, I know I sound like a broken record, but do not give fluids. You want to diurese these people. If they don't have any signs of excessive preload, then you still want to limit the amount of fluids you're giving and not giving extra fluids to these people because they're not going to handle it well if they have high afterload. So you can diurese because they have such high venous pressures and they have such low arterial blood flow. Both of those things together make the kidney work really poorly. So oftentimes these people are really, really resistant to diuretics. And that's really hard unless you change a bunch of their hemodynamics, is that you may never see them be able to start making urine on their own. And so there's always a real quick threshold, low threshold to start ultrafiltration or dialysis on these patients because you need to get that volume off. And then it's just the hemodynamics don't really work well for diuretics. For some people, if you can get the right medications on, they'll start really making a bunch of urine and looking better. But again, low threshold to say, look, we've given it a couple hours, they're not making any urine, they have a severely dilated right heart, we need to start getting this person on dialysis. Next is excessive afterload, which again is very common in all of these types of things. And the first thing you want to do is correct those factors that we talked about, things that you can correct on a systemic level that are easy to do. So you want to fix hypoxia, fix acidosis, figure out what their lung volumes are. You want to optimize their lung volumes. So if you need to put them on positive pressure, if they're morbidly obese with significant atelectasis, then you just need to, they usually handle it well. But if you're worried about their lung volumes, if they're intubated, you kind of want to lower their pressures to a point that you feel like is optimized. So you really want to pay attention to all these things that'll help lower the pulmonary vascular resistance. And then you want to keep looking at it. If they still seem high, then you want to start moving to pulmonary vasodilators. And I know this isn't commonly done in the emergency department, but I do want to mention that there's things that can be done if they're still down in the emergency department, if they're significantly struggling, is that if there is a way that you guys can get these certain ones, it can make a really big difference. And there's a whole list of ones, but the ones that are going to be helpful for you are going to be the inhaled ones. There's a number of reasons for this. It's easy to do. You just put it through the vent, or you can put it through a high flow or a BiPAP, some device that'll help it go through on there. And then you can do inhaled epiprostenol, which is a prostaglandin, versus inhaled nitric oxide. The benefits are that the inhaled ones don't cause lowering of the blood pressure. And ideally, you're only dilating arteries attached or capillaries attached to your alveoli. And so you're optimizing that VQ matching. You're making it easier for the body to work that way, and it can improve oxygenation, which is also helpful. So the inhaled ones in the acute phase are very important. If you have a struggling PE patient, right, this is going to be huge for them if they're waiting to decide whether or not they're going to go get TPA or go for like a ECOS, if you guys do that, or a catheter-directed TPA, is that this will help get you through in these because it's going to help lower that pulmonary vascular resistance. And then decreased RV perfusion. And we kind of talked about the fact that it's a thin wall, is that it's very easily gets overworked, and then you start getting ischemia. And so you want to make sure that you don't get hypotensive with these people. And in fact, we usually do a MAP goal of 70 because of the way that the RV having that wall strain. is that if you do a MAP goal, you're talking about coronary perfusion pressure. So you already know that you have a high CVP from the RV failure. So you're going to do a little bit of a MAP push. So instead of a MAP goal of 65, you're going to do a MAP goal of 70. That's going to help that RV perfusion. There's a couple of situations where I will automatically put vasopressin as a first line agent. And this is one of them. So vasopressin at low doses, which is the shock doses, will lower pulmonary vascular resistance, but increase systemic vascular resistance. So I will use vasopressor as a first line drug in these patients because it's going to help with the hemodynamics. I also do it in cirrhotic patients as well. That the same thing, it's going to help constrict the portal pressures whenever you have it, and going to be able to help do it that way. So there are a couple of situations where I'll reach for vasopressin first, and this is definitely one of them. You want vasopressin on, and then if you're not reaching your MAP goals, you can add norepinephrine on top of that. You definitely don't want to do phenylephrine. Epi does help because it is contractility as well as vasopressor, but vasopressin should be your first choice. And then decreased RV contractility. So you've done your TAPSE, you know that it's reduced, it's less than 1.7. That's going to make it harder for that RV to kind of push volume from the right side to the left side. So you want to be quick to put them on some sort of an inotrope. And again, epi does count, you can use it. I'll typically reach for either dobutamine or milrinone. Milrinone is usually the first one I'll reach for just because it lowers pulmonary vascular resistance. But it does drop your blood pressure a lot, and it has a long half-life. So it takes about 3 to 4 hours to really reach steady state, whereas dobutamine doesn't really help with the pulmonary vascular resistance, but it's quick on, quick off. So I would say milrinone if you have time to be able to do these types of things. And then if none of these things are working, they're still in RV failure, you have to consider going to ECMO. And so in these situations, you'd either need, you could do an RVAD, which is not very common these days, versus VA ECMO. And VA ECMO is actually great in these situations. It works for acute PEs. It works for acute on chronic right heart failure. Because you're taking that blood that's over distended on the venous side, you have all this blood on the venous side and it's not getting to the arterial side. So VA ECMO takes it from the venous side and puts it into the arterial side, and they'll get better immediately, and they'll look a whole lot better with that situation. This is kind of my cocktail that I'll go to, is that anytime it looks like someone has high afterload, decreased contractility, increased preload, these are kind of the 4 medications that I'll order to kind of get their RV hemodynamics better so that we can start getting them feeling better. Invasive monitoring, you're not going to do. So what you want to do is, if they are continuing to be in the emergency department, after you do an intervention, you can re-look at them. Is their tricuspid regurg better? Is their tricuspid regurg velocity better? Do they now not have a D-sign where they had a D-sign before? Is their TAPSE better now that we've started an inotrope? So these are all things you can just go back to the patient, look with your ultrasound and say, hey, these things look better than they did before. Maybe what we're doing is helping out. So you can monitor them by doing it that way. So we're going to look at these cases again, and I'm hoping that as we look at them and you look at these reads, that they'll start to make a little more sense to you, right? So you have this person, they have severe tricuspid regurg. They have an RV-RA pressure gradient of 34. So if you add that to their CVP, that's going to be an estimated pulmonary artery systolic pressure. Their IVC is moderately dilated with no collapse. They have systolic septal flattening consistent with RV pressure overload. Their LV cavity is small, their LV is hyperdynamic, their EF is greater than 70%. So they have all sorts of volume on the right heart and no volume in the left heart. So this person is in significant RV failure. But as what often happens is that you get a patient, and this is the patient that says diabetes, end-stage renal, cirrhotic, altered. They have a lactate of 11, they're hypotensive, so immediately they get 2 liters in the ED. And as you can guess, what happens with an echo like that is they immediately get worse. They get transferred to the ICU and get intubated from that standpoint. So if you re-look at it, you can just see this person did not need fluid. They had all sorts of fluid. They had a dilated IVC. They had all sorts of things in there, but that the real problem was that it just wasn't getting to the other side. So they were started on milrinone. They were started on vasopressin and inhaled Flolan. A trialysis or hemodialysis catheter was placed. CRT was started. 6 liters negative on day 1, 4 liters negative on day 2. Started on sildenafil to help wean off of the inhaled. And they tolerated regular dialysis, and they were downgraded whenever they had it. So once you actually optimize their RV hemodynamics, then they start coming off all those pressors to be able to do those things. Case 2, right? You have that normal EF, but you have a decreased CAPC. They also have an IVC that's moderately dilated with no collapse. Systolic flow reversal of the hepatic vein. So it actually did the Bexus protocol for you. So you have reversal of flow. You have pulsatility in your right side in your venous system, and your estimated RVSP is 57 plus whatever the right atrial pressure is, which is at least 15 based on the estimation of the IVC. So you're looking at a pulmonary artery systolic pressure of 70. So they have severe pulmonary hypertension, and they have like no movement of their atria. It's at a standstill. So again, this person comes in hypothermic, hypotensive, and bradycardic. So immediately 2 liters of fluid. And they were started on dopamine and admitted to the ICU. And again, we look, this person is not somebody that's going to do well with fluids because they already have a pulsatile liver from increased preload and all these issues. So they decompensate as soon as they get to the ICU, they get intubated. The TAPC was 1.1, so severely decreased. They were warmed, added dobutamine and vasopressin and furosemide, immediately started making a bunch of urine. They were warmed up, they were extubated, came off pressors, and then transferred out of the ICU on day 2. But you can see as soon as you optimize that right ventricle that they tend to do considerably better. Here's a patient, again, EF 60 to 65%, but if you look, they have a severely increased left atrial volume, moderate mitral regurg. So their RVSP, their estimated pulmonary pressures are 65 to 70. So they have severe pulmonary hypertension. But in somebody that has moderate mitral regurg, it's probably due to their left heart. So in this situation, you probably want to focus on their left heart. So the history is diastolic dysfunction, moderate mitral regurg, COPD, and OSA, which puts you at increased risk for those high pulmonary pressures. But on visit 1 to the ED, they were treated for bilateral pneumonia with no white count and no fever. And then the next visit, which was a couple of days later, in respiratory distress, they got a dose of Lasix and sent home. And then they come back 2 days later in severe respiratory distress, placed on BiPAP, ended up getting intubated, bilateral infiltrates, bilateral pleural effusions, and they treated her again for multilobar pneumonia and admitted to the medical ICU. Now you can see is that this person has all the things that put a recipe for them to have pretty significant pulmonary edema. You have this moderate mitral regurg with diastolic dysfunction. So when she gets into stress, she's going to easily get into flash pulmonary edema. She's going to easily have a lot of issues with having pulmonary edema in her lungs. And then now she's getting treated for all these pneumonias because she wasn't volume overloaded. Like if you looked at her, she didn't have that 3+ edema in her lower extremities. So she was weaned to high flow and transferred out of the ICU with nothing else done. The echo was done on day 1. Her renal function continued to decline because she had so much volume on her right side. She was having renal venous congestion. Again, they were concerned for multilobar pneumonia. They decided that she went into ARDS. They gave her 4 liters of fluid. And then obviously she immediately was intubated and readmitted to the ICU. Worsened respiratory status. At that point, she was started on a Lasix drip. She was making 0 urine. They proned and paralyzed her from an ARDS standpoint. And then finally, she was started on inhaled epoprostenol due to that, the hypoxia and the prone and paralyzed, and her oxygenation did improve. Now, this was due to her left heart, so it didn't really help anything in terms of helping her hemodynamics. But the family decided that she wouldn't want to go through this after being in there for a week and gave comfort measures. But if you look, this is somebody who isn't going to handle fluids well. It's probably, she never grew anything on any culture that was done on the 3 visits, and that this was probably all cardiac that was being misdiagnosed, and she was got multiple liters of fluid in somebody with diastolic dysfunction and moderate mitral regurg. So she never had a cardiology or heart failure consult. They never diagnosed that she had pulmonary hypertension. And then they ended up withdrawing on her. So these are kind of the objectives that we kind of went over in terms of recognizing them, understanding the hemodynamics, differentiating the different types. We went over the pathophysiology of right heart failure and then getting decompensated, and then how to diagnose it in the emergency department, and then what you can do in terms of treating it. So just to address, obviously a lot of these things you're probably not necessarily going to be doing in the emergency department. And I acknowledge that a lot of these things are going to be set up when they're in the ICU or when they're in the hospital. But there's things that you can do in the ED. Pay attention to the previous echoes. So in those 3 cases, all 3 of those echoes were in the chart from previous admissions. And if someone had just taken the time and said, look at these previous echoes, these people are not going to tolerate fluid very well. These people have a lot of pulmonary hypertension, RV dysfunction. Maybe we need to consider something else, that maybe they would have not ended up in the ICU. Do not give these patients fluids. Try to avoid it, try to look, try to see, evaluate before, so that you're not causing them to decompensate whenever they have it. Start inotropes and vasopressors as needed. So if you have somebody in this acute on chronic or decompensated RV failure, is maybe consider reaching for melrinone and vasopressin as opposed to just the levofed, and kind of optimizing them while you're working them up to get admitted to the intensive care unit. Start diuresis early. So if you see these people, is by starting this diuresis, what it's going to do is it's going to decompress the RV and allow the RV to work better. So the faster they can get their RV decompressed, the shorter their hospital stays that they're going to have. So you definitely want to consider that if you feel like they have too much preload. And then if you're able and you have somebody that's severely decompensated and it's not doing well and you're looking at something to do, is there may be a potential that you could start inhaled pulmonary vasodilators in the emergency department. And then consider admitting to the CCU instead of the ICU in people that are acute on chronic right heart failure. Depending on how your hospital is or how well staffed their CCU is by recognizing that it's decompensated right heart failure, is that going to a cardiac care unit may have some benefit. So just keep in mind that it's often ignored or under-recognized. D sign or pulsatile IVC means volume or pressure overload. Look at the TAPSE for signs of RV failure. Look for patients at high risk for pulmonary hypertension and RV failure. And then shock with a normal EF is not always sepsis. Make sure you take an extra look. And that is it. And I'm happy to take any questions.
You see any questions here in person, Michael? I don't know if anyone is on the chat. Say it again, sorry.
Suvam on the chat is asking if there's a role for nebulized nitro, since we don't really have nitro outside.
I don't know if you heard that, Dr. Ritchie. Is there a role for nebulized nitro, since if we don't have other medications to give?
Sure. I know that there's a role for nebulized milrinone. There's actually a really good talk that a doctor gave on EM Crit probably about a year ago, and they looked at this issue where she was at a hospital that had no resources, but did have milrinone, and she nebulized milrinone and was able to get that pulmonary vasodilatation that she needed. I've never used the nitroglycerin, so I'm not 100% on it. I know that she gave a list of things that could be used, and I just can't remember if that was on
there. I think there's a hope that they did it
during
we're
COVID.
running out of
The comment was that anecdotally people have used it, and definitely during COVID.
Okay.
Would you give like inhaled nitro?
I think it's probably going to be the same answer. Would you give inhaled nitro to a massive PE? I mean, that's going to be right heart failure if it gets to that level. So I think it's not good evidence, but maybe something to consider.
Yeah, I mean, I think if the person's decompensating, I definitely will give inhaled pulmonary vasodilators. If that can get up there faster than the TPA or the embolectomy or whatever's needed, or if they're not a candidate for some reason, then just anything to kind of take the pressure off the RV is going to be beneficial. So I will use it. It's just one of those things. It's like it's that or they're going to die. So just try to do whatever you can to take the pressure off the RV. And then is there a proven benefit of admission to a dedicated heart failure unit as opposed to a CCU? That I'm not sure of. I know having heart failure on board with these patients does lead to better outcomes. I know that having an intensivist in a CCU or a ICU standpoint has led to better outcomes, but in terms of like a dedicated heart failure unit versus CCU, I'm not sure. Would I consider vasodilators before intubating and increasing the pulmonary vascular resistance? Yeah, I mean, especially those people that those massive PEs. I mean, oftentimes it's just hard to get it organized. Like if they're stable and I can get them on a high flow device with a pulmonary vasodilator and that helps relieve their work of breathing so I don't have to intubate them, then that's my ultimate goal. Most of the time, if I have to intubate these patients and I'm really worried about how they're going to handle that quick increase in positive pressure, is that I'll bring their maps up really high. Like I'll bring it up way above 70, closer to 80, and just try to get as much RV perfusion and function as we can. And whether or not that's done with epi because it has a little bit more inotropy, or just done with your levofed, but I've had more success where they don't just become profoundly hypotensive after intubation if we do kind of a map push beforehand.
Great. Thank you so much, Dr. Ritchie. Great to have you back talking to us.
Thank you.